A very good day to you all, friends. At the outset, I'd like to thank Dr. Rajiv Sukumaran for asking me to conduct this instruction course titled Premium IOL Practice. I am Arup Chakrabarti, and we have no financial interest in the contents of this instruction course. And we have Dr. Ronald Yeoh from Singapore delivering a very important talk on how do I select a presbyopia correcting intraocular lenses in a given patient.
Hello, thank you for inviting me to speak at this great meeting. I've been tasked to speak on the topic of how I select or choose a presbyopia correcting IOL. And as you can see from the preceding speakers, there are so many lens implants out there that correct presbyopia. But before I talk about choosing, I'd like to just share with you a little bit about the philosophy of using presbyopia correcting IOLs. Are you a believer in presbyopia correction at the time of cataract surgery? Or do you think patients should just wear reading glasses, in which case this talk is perhaps wasted on you? Now, what is your patient's usual response to the diagnosis of cataract? Many of my patients hold their hands up like that and say, "Oh dear, I've got a cataract." And I tell them, really, this is what you should be feeling. You should be saying, "Hooray," and jump in the sky. And they usually look at me in puzzlement and ask why. And I tell them, well, this is because we will make you better than you ever were since you were a young person. How so? Well, this is so only if you choose to perform presby correction. For example, the myope will gain distance vision, the hyperope will gain near vision, the emmetrope will gain near vision, and the astigmat will actually gain both. Remember, our job as physicians is to make our patients' lives better. But we must also not forget what William Osler said to all doctors: above all, do no harm. And this, of course, refers to putting in, say, a trifocal lens in a patient who should not have it in the first place. And I put it to you that presbyopia correction really should be offered to every patient. Now, the IOLs available are many, and we can choose to correct presbyopia just by simple monofocal IOLs, opting for monovision, or we can do EDOF lenses bilaterally, monocularly, or we use EDOF to do monovision to reduce the anisometropia. We can, of course, use trifocals to correct cataract-related presbyopia, but in every case, it's absolutely crucial to do toric correction for surgery. Now, because there's so many presbyopic correcting IOLs out there, you need to be familiar with as many good IOL options as you can be. How do you do this? Well, number one, I would say, is to speak with trustworthy colleagues whose opinions you value. And I would usually ask them, what is your favorite multifocal IOL? What's the most commonly implanted one? Or what's your most favorite EDOF IOL? You need to distinguish the bells and whistles from true advances in technology. You need to look at the data, because that's the only way you're going to know whether it's safe to implant this lens in your patient's eyes. So at the end of the day, how do we choose and what do we recommend? Well, it's actually impossible to generalize, but I'm going to generalize anyway because we kind of have to, and say that really it's horses for courses. There's probably a suitable IOL for each patient of yours, and in some patients, they actually can have any IOL. So strategies. You need to decide, what do patients want? Do they want spectacle freedom or not? How's their lifestyle balance? Are they an outdoor person, or are they mainly indoors reading all the time? Or do they lead a balanced lifestyle, which is what most people do? And how tolerant are they of dysphotopsias? And that ties in with their personality type. So let's have a few examples. Say you've got this easygoing patient who really wants a full range of vision. That's easy. You give them any good trifocal lens, bearing in mind that modern trifocals have gone so many sort of generations of development that dysphotopsias are really quite mild today. And if you have a patient who's hyperopic or significantly myopic, they're going to be happy really regardless of what you put in to their eyes. You just have to be a little bit careful of the low myopes who can already see for near without glasses. Now, what if a patient wants far and near vision but has this slightly more complex personality and doesn't want any risk of dysphotopsia? Well, in this case, I would consider using one of the new EDOF IOLs like Vivity, but they may or may not get the full range of vision and you need to counsel them for this. Now, what if the patient wants far and intermediate? Well, that's easy as well. You just give them an EDOF, stress that they may not get near, but if they do, it's a bonus. Now, what if price is an issue and the patient wants far and intermediate vision, but at a reasonable price? Well, monovision with a monofocal IOL aiming for, say, -1.5 diopters in the non-dominant eye is probably the cheapest option, and this tried and tested method I think really works very well. But if you want to put in an eye hans, because the eye hans is also very cheap, you can aim for just 1 diopter minus in the non-dominant eye, and that reduces anisometropia. And of course, if you use the latest Vivity IOL in the non-dominant eye, you can actually aim only for half a diopter because of the built-in 1.5 diopters in the Vivity. We mustn't forget that patients with mild eye pathology can also benefit from presbyopia correction. And these would be patients with mild dry AMD or RPE disturbance, quiet, controlled, non-proliferative diabetic eye disease, glaucoma with mild field loss, and some patients with ERMs or partial thickness macular holes. In these, I would consider either an eye hans or a Vivity, and they will get a little bit of intermediate vision, which they can be quite happy with. Now here I'd like to share with you a couple of concepts that I think is important when you're embarking on your presbyopia correcting journey. And this is the concept of a target refraction, to get the most out of any IOL and to finesse the result for each individual patient. Well, what does this mean? This means that, should you target plano first plus, that's usually true for the trifocals, or do you go first minus, which is often the case for the EDOF lenses? And how do you apply monovision? Do you go for micro, mini, or full monovision options as you see here? But that's only effective if you know what is the effective ad for each IOL. And this is something that manufacturers don't often tell us. And here we see that for the monofocal IOL, it's actually minimal. For an eye hans, it's about 1/2 to 3/4 of a diopter. For a Vivity, it's 1.5 diopters. And Vivity is the first lens that really tells us what the ad is. You can see the code name is DFT015, which tells us it's 1.5 diopters. And Panoptix and Synergy, of course, give us 1.5 to 3.5 diopters of effective ad. So ultimately, I would say to you that it's actually horses for courses. You know all the IOLs available, you know what the target should be, and then you know how to modify each of these ads so that your patient who has and each patient has an individual need and has a different sort of lifestyle, can then be tailored, or the IOL can be tailored to that particular patient's needs. And that's why we set the term horses for courses. So thank you very much. And I'd like to welcome all of you to next year's APACRS, which is scheduled to be in Seoul, South Korea on the 10th to 12th June 2022. But COVID permitting, we'll hold a physical meeting. But if not, we will hold another absolutely brilliant virtual meeting for all of you. Thank you.